All right, everybody. Thank you so much. Dr. Zemp is here. We're going to go over advances in penile cancer. He comes from one of the world centers of excellence on this topic. Logan Zemp, like most of us, was born. He's from Alberta, Canada, where he did his residency in urology. He completed his SUO fellowship at Moffitt Cancer Center in Tampa, Florida, where they loved him so much they kept him on as faculty. He is a wonderful teacher and a guardian of the fellows. He's so good, they made him assistant fellowship director within 2 years of practice. He's an excellent husband to his wife, Amy, an incredible dad to his daughters, Zoe, Beth, and Goldie. He's an absolute force to be reckoned with in the OR, and I can confidently say that I would not have enjoyed the last 2 years without his surgical guidance and teaching. Most importantly, he's a great friend and mentor. Please welcome Dr. Logan Zemp.
I've been trying to get Dr. Rose to call me Logan for about 4 years now, so he's a very nice introduction. Thank you very much. Penile cancer. This is a disease state that is challenging, and it is a little bit of a love-hate relationship, mostly on the hate side, because it is really challenging for the patients, and sometimes it can be very difficult. From a disclosure perspective, no financial disclosures, but there are no penis pictures in this talk, even though it's a penile cancer talk. So it's just some basics on penile cancer. It's usually a skin abnormality found on the penis, typically on the glands. About a quarter of people will show up with like a painless ulcer or a painless lump. Some will have ulcers. Some may have bleeding. These can be very painful. This is usually found in men in their 60s, but as anybody who treats penile cancer, you can see people in their 30s or even younger, and then all the way up till until death, you can find this. The big problem here is that there's always a delay. It's not that you can't see it, you can't feel it, but there's something in that Y chromosome that says, I'm not going to the doctor. And so there's this 6 to 12 month delay in presentation. When people show up, 30 to 60% have local or local regional disease, meaning that you can have clinically enlarged lymph nodes, half of which are malignant. Fortunately, only 10% show up with metastatic disease. So how prevalent is this? If we looked at the world, we looked at these heat maps, or we looked at the number that's I put on there, it's pretty low, 0.8 per 100,000. It's focused in underdeveloped countries, South America, parts of Africa, and India. These are the incidence rates, and then the mortality rates kind of follow those. But what about, how does it hit home? How does it hit here in Louisiana? So out of the approximately 14,000 males diagnosed with cancer, 22 of those were penile cancer in the state of Louisiana over this time period. And then how many deaths? 4 deaths per year. So I was calculating that, that's like 0.001% of deaths for cancer. So it's an awful disease for patients who have it. Fortunately, it doesn't happen very much. And unfortunately, because it's so uncommon, some of the data that we have is not as strong as what we just had presented. So what's the prevalence if somebody had penile cancer in the state of Louisiana? 66%, which is probably keeping in lines with other states. So there is a TNM stage, so the primary tumor staging. We think that it's important. So that if it's just on the subepithelial tissue, if there's no perineural invasion, no sarcomatoid features, that's a T1A. And those people, for the residents in the room, those are the ones that you just observed. That doesn't mean that you can't have inguinal lymph node metastases, and Dr. Rose and I were talking about a patient like that last night. But if you have this T1B disease, so if you have any additional risk factors, then you have additional risks of having disease in your inguinal areas. So penile cancer spreads in a very predictable pathway. It doesn't skip. It goes from penis to the groin to the pelvis then it can go anywhere. So it's important to manage it. When we look at the nodal staging, this is the most important. I'll show you on the next slide why. But if we are looking at people who have enlarged lymph nodes greater than 4 centimeters and they're fixed, almost 95% of those will have pathologic disease when you take those lymph nodes out. They won't be inflammatory, there'll be cancer there. And then if you have these pathologic nodes, so you have greater than 3 on one side or bilateral inguinal lymph nodes, there's about a 23% risk that you have pelvic nodes or this extranodal extension, ENE is what that stands for. It's a flip of the coin if you're going to have pelvic disease. And that extranodal extension is a bad actor. So what are the survival rates of penile cancer? So if you are in this PN0, meaning there's no cancer there, when you do a lymph node dissection, you're going to live a long time. But if you have, extranodal extension, one lymph node that has it sneaking out of the lymph node, then your 5-year survival is about 37%. And it's rarely cured by surgery alone, so it's a really multidisciplinary disease. So I want to pause here, looking at those nodal stagings. So if there is anything from my talk, one, penile cancer is uncommon, it's rare, it's bad, but if we just did a little bit better job in educating young men, I mean, we talk about sexual education all the time in schools and whatnot. If we took a time and did some advocacy and just said, hey, if you have a weird lump, it's not embarrassing to go talk to your doctor, that would save a lot of people who die from penile cancer. I love these kind of I just searched the internet. Know what's under your kilt. This was Thai. I had to use Google Translate. It's penile cancer, but still not a penis on the screen. So if somebody shows up with penile cancer, history and physical exam, do some imaging. Typically, we would get a CT of the thorax, abdomen, and pelvis. You can do an aspiration cytology, so a biopsy. That will, if it says it's cancer, it's cancer. It can help show candidacy for neoadjuvant chemotherapy and might guide which way you're doing your lymph node dissection or which order, kind of the sequence. And then there's surgical staging. I just want to mention PET scans really quick. PET scans are all the rage. People come in, they've got a PET scan. They ask me, Dr. Zemp, can I get a cancerogram? I'm like, are you talking about a PET scan? Yes. But they're not super useful if they don't have, clinically palpable nodes. So don't get them. But if they do have clinically palpable nodes, then it's pretty good at picking them up. And it may be a help to on restaging if they get neoadjuvant chemotherapy. So that's something to consider. Let's talk about some of the surgical staging. Let's throw a dynamic sentinel lymph node biopsy. It was first described in 1977. It didn't have an awesome false negative rate, so 20% of the time there was still cancer there. It's been refined over in Europe. They're big proponents. They essentially get this injection of a technetium-99 nanocolloid into the lesion, the primary lesion, or at the base of the penis if they've already undergone a partial penectomy or a total penectomy. And then we get to use these fancy Geiger counters, and the radiologist, it's like Indiana Jones, X marks the spot. They mark it out, we make an incision, we take out the lymph nodes. So in the modern era, when they looked at 130 patients, they got 425 sentinel lymph nodes. They had a pretty good detection rate, but when they had they have this false negative rate of 12% per groin. In this study, they had 3 recurrences. All those recurrences ended in death. So I've had one patient like this, and it really kind of changed how I thought about this and how I practice. So it should be done in high volume centers where I see multiple cases, but this is a good way to stage them. So what about, staging? There is kind of a pseudo staging. Looking at the SEER database, only about 25% of people undergo guideline directed care for penile cancer, and probably it's because it's a rare cancer. So we have this kind of surveillance cohort. So when you looked at the 5-year cancer specific mortality of people who underwent a lymph node dissection versus those who didn't, if they didn't have nodes, if they clinically didn't have nodes, it was pretty even. But if they had a clinically node positive area and they went under surveillance, then their outcomes were far less favorable. Often, as urologists, we see people who've had resection of their primary tumors. They might also need inguinal lymph node dissections. So when is the timing? Because it is to do a partial penectomy, get a diagnosis, and then to move on to the groins. Sometimes that's very challenging. So this is a study of about 900 patients, multi-institutional, international, that Dr. Rose was a part of as well. 253 of them had clinically positive nodes, so they were palpable. You could feel them in the groins. 88% of them had node positives, and you can see the breakdown of PN 1, 2, and 3. But there was no difference if there was a delay in a few months from their primary tumor for their recurrence-free survival, their cancer-specific survival, and their overall survival. So that may be because some of those people were getting chemotherapy up front. It's hard to say. So how do we when we're fully going to assess those lymph nodes? We make some incisions, and there's a couple ways to do this, open and robotic, and we'll talk about both of them. So the one on the left that has a red box around is just a straight line, 1 centimeter under the inguinal crease, approximately 10 centimeters. And that's the way that we typically recommend. These S-shaped curves and multiple incisions are not super favorable for patient outcomes, and we'll talk about that. But I'll show you in the next slide what you can do from just a small, maybe not small, but an incision in the groin. This is a gentleman from a few weeks ago who was on an impact trial that we'll talk about. This is his right and his left groin. So you can see his sartorius muscle here. You can see his left femoral artery, left femoral vein, his saphenous vein was spared. This is his femoral nerve coming around the bottom. So you don't need a huge incision, but you can do an extensive lymph node dissection. But what is the cost of doing an extensive lymph node dissection? So 50 to 60% of these people will have some kind of complication. Most of these are kind of wound-related, skin-related, infection-related. You can get lymphatic tissue or lymphatic fluid, a seroma, that can be infected. And about a third of them will have major complications requiring, either some intervention or a trip to the operating room. The only thing that, when you looked at univariate and multivariate analysis, that predicted why that might happen is the number of lymph nodes that you remove. So more surgery equals more outcomes. You do big surgery, you're going to do you get bigger outcome or bigger complication rates. These patients aren't always like skinny, healthy patients. I don't know what the population of Louisiana exactly looks like, but at least in Florida, you pretty much counsel patients that you're going to have a complication and we're going to deal with it when it gets there. But taking out those lymph nodes, if we looked at multiple studies, these are all surgeon-led studies, then we all like to say we take out lymph nodes, we do a great job. But when you look at these, if we take out more lymph nodes, higher chance that all the cancer is removed. And so it improves your 5-year cancer-specific survival based on your lymph nodes. I don't know if the correct number is 8 or number is 15. 15 is actually kind of hard to get unless you do a very extensive lymph node dissection. So how might we limit some of those complications? We are, as a urologic community, we are very comfortable with robotic surgery. Still no penis in this picture. Doing a robotic assisted surgery. So putting ports, doing a minimally invasive, instead of the lymph nodes going down on them, they're kind of up above you. You can use this fancy ICG and use Firefly on the robot to see where lymph nodes are. And I think this is nice. I'm not sure it's the best for like bulky lymph nodes. Actually, it would be recommended against it. But this is a nice way to potentially cut back on some of those skin-related complications. There's a study, this is the only study that really has positive lymph nodes on pathology for robotic surgery. They looked at approximately 300 patients, 250 which were open, 40 were underwent a robotic surgery, what it showed is that there was no difference between the number of nodes taken out and the number of affected nodes. It was longer to use the robot. There was less skin-related complications, but because of when we use the robot, you kind of like, instead of putting titanium clips on lymphatics, you burn it. There was actually a little bit higher lymphatic issues. So it's still an option. The EUA and ASCO guidelines say that, maybe we shouldn't do that. I don't know if I necessarily agree, but I do agree that if they have bulky lymph nodes, it's probably not a good idea. Pelvic lymph node dissection, if you have those, adverse features on the inguinal lymph node dissection, you should undergo a pelvic lymph node dissection, although as a community, we're not 100% sure of what the true benefit of that will be. But we do know that if they, on dissection, if you have no lymph nodes in the pelvis that were positive, then you're going to do better. But when you looked at the 5-year overall survival of patients who had those lymph node dissections, their survival is actually fairly similar. It looks like 35 versus 25 looks good, but it's not statistically significant. So let's talk about chemotherapy. Chemotherapy is it is a important part of penile cancer management, although this sentinel study is a very low number of patients. So they get this TIP chemotherapy, and it's really based off of their objective response rate of 50%. So this is only 30 patients, but this is in a setting before people underwent surgery. Of these 30 patients, 22 underwent surgery, and there was a complete response rate of about 10%, which is not awesome, but it's something. And then there was 30% that remain alive and free. So this has kind of been the lead of the basis of the chemotherapy, because the other stuff before it was worse. This is a really toxic regime and typically requires inpatient chemotherapy. So it's challenging from patient perspective, from a healthcare perspective as well. Dr. Necki is not a urologic oncologist. He's a medical oncologist out of Italy, and he was looking at these, chemotherapy in different settings. So NAC is neoadjuvant, meaning before surgery. Adjuvant is after surgery. These survival curves look okay, but the only one that's significant is actually the one on the far right. And this is if he's pathologic N3 because they had lymph nodes resected in the pelvis. And so essentially based off that sentinel study, the Pagliaro study, it's recommended neoadjuvant chemotherapy may be recommended. If you have pelvic lymph nodes that are positive, then adjuvant chemotherapy or chemotherapy after surgery. But if you have this extranodal extension, meaning it's sneaking out of the lymph node, then it is potentially, it's important to get radiation therapy. This is a study, a meta-analysis of 800-ish patients who got chemotherapy after resection, and there was we would like to see this diamond move, over to favors adjuvant, or, one way or the other, but it's right down the middle. So it's hard there's not a lot of data, even though it's, I think you do as much as you can for a patient. So what about adjuvant radiation therapy? So this is that extranodal extension. It could be one node. It could have this extranodal extension that's a bad actor. So we advocate that patients get radiation therapy. So they have 50 to 54 gray and 25 fractions. They radiate the ipsilateral groin and pelvis, and the 5-year oncologic outcomes are, recurrence-free survival, cancer-specific survival, 51% each, and overall survival, 44%. But when you look at adjuvant radiation therapy, the median overall survival is 48 months versus adjuvant chemo, which is 15 months less. So that was something that was interesting from these studies. Now we need to, no penile cancer talk is complete without talking about this International Penile Advanced Cancer Trial impact. So this is a huge effort, a surgical trial, but it is also looking at the benefits of adjuvant or neoadjuvant therapy. This was initially planned to be about a 400 patient accrual that after slow accrual, the goal was cut down to 200. And as of 3 days ago when I emailed Dr. Petaway, we're 3/4 of the way, so 150 patients. So we hope to be finished by next year. There are 2 questions that are supposed to be answered here. This is question 1, part A, part B. It feels like a urology conference. What is the role of neoadjuvant therapy? And 2, does either chemotherapy or chemoradiation therapy provide superior outcomes? And then what do we do? What is the pelvis? Like, how do we manage the pelvis? What's the role? Based on current accruals, we should be able to answer this question: does either chemotherapy or chemoradiation therapy provide superior outcomes? So the question of, is neoadjuvant chemotherapy good? We'll find out in the next couple of years. This is what the study looks like. If you had inguinal lymph node involvement of penile cancer, you can be randomized into 3 arms. Arm A is a surgery-only group. Arm B is a chemotherapy followed by surgery group. Arm C is a chemo radiation group followed by resection. Then you can be randomized into this second, and it's really based on your prior chemotherapy. And then you can either get a prophylactic lymph node dissection or adjuvant chemotherapy, or surveillance or prophylactic lymph node dissection. This part of the study is going to be totally descriptive, and it won't have statistical power. It'll just be interesting. So what happens? So let's say that Dr. Rose takes somebody for surgery. Not this would ever happen to him. It happened to me a couple weeks ago, but somebody had a recurrence of their penile cancer after we've operated on them. So the line that you want to be on is that top red line. That's the no recurrence. But if you had a local recurrence, meaning if you had a recurrence in the penis, then your survival is going to be about the same as if you didn't, because that can be salvaged. But if you get a recurrence within your groin or in your pelvis or distantly, those outcomes are fairly abysmal. Even though we would potentially operate and radiate those areas, it is challenging. This is a study of 551 patients, and so fairly large population. This was one of our former fellows who put this together. So we need to, we looked at the chemotherapy has only a 10% complete response rate. So can we do something better? So there are a bunch of targetable alterations in penile cancer, EGFR, Nectin, TROP2, c-Met, a lot of these immunotherapy targets or targeted therapy targets. So these are potentials, and trials can be ongoing, some of which are right here. So dacramitinib, cabozantinib, objective response rates of 33%. So they're a little bit better, but not by much. Then I have this one on the bottom that's kind of a new player in the field, a study out of China. I only have the phase 1 data, and the phase 2 data is supposed to come out in about a month of 45 patients. But what they did is they used a EGFR receptor, a PD-1 inhibitor, and then EGFR blockade, and then TIP chemotherapy. And look, they had 17 patients who were non-resectable or metastatic, after which 12 underwent consolidative surgery, and 75% of those did not have cancer remaining. So this is like throwing the kitchen sink at somebody, like almost everything. It's interesting, it's exploratory. It's hard to 100% believe, because about the complication rate of TIP chemotherapy alone is probably about 47%. So adding a couple other medications not sure, but we'll see from the phase 2 trial. And then what about immune checkpoint inhibitors in penile cancer? There's some real world data, 92 patients. Nobody had the exact same regime, but when you put these patients in, and looking at their overall survival of 9 to 10 months, their objective response rates were 13 to 35%. There's room for improvement. And then there are ongoing immune checkpoint trials. Of note, these are all in like recurrent penile cancer after a resection or failure of traditional chemotherapy. We don't have any, combination neoadjuvant or prior to surgery trials, and those I think will be coming. I think this is, treat people in the metastatic setting and then try to move things up in the treatment algorithm. So, biggest things. Penile cancer is bad. Penile cancer awareness, if we just taught young men to seek help when they need it, or old men when they need it, we could avoid a lot of these things. I think multi-disciplinary management is really important. So it's not just a urologist making the decisions, it's a medical oncologist, radiation oncologist, because that's what these patients deserve. And then the more you see, the more these treatment algorithms will be important. Most of these patients should be considered for one clinical trial or another, and there are trials open that are like basket trials that they might be able to get on with these therapies, and I think that would be really important. These are a couple of the surgeons that I left at home. This is their career day. And Beth there is ripping out a kidney that we transplanted the night before. So thank you very much. Pleasure to be here.
Criteria. Thank you. We could meet that criteria by all cancer types, not just testis cancer. But you're right. There is a phenomenon that the rich could get richer, and there are also surgeons in the country that think they should be the only ones doing those surgeries that we obviously wouldn't agree with for several reasons.
I think that's something that we can think about too here. We talk a lot about getting people to high volume centers, to getting to experienced surgeons, to getting people onto clinical trials, thinking about people that might have next line therapy for metastatic penile cancer, things like that. It's probably something that we could think about here as an organization like CAGLA, like how do you advocate for your patients to get to these centers? Not all of us are lucky enough to get our penile cancer living in Houston or New York or Tampa or New Orleans. A lot of penis cancers are coming up in places that are not around these areas. So I think we do need to put some thought into how do we get folks to these areas, and are there ways that we can move that forward? Okay. Yeah.
Can I make a comment? So I don't think, I think penile cancer, the management of the primary penile cancer can certainly be done by a general urologist to make sure you don't have a delay in care. But it's really if, not holding on to that patient, not delaying them and referring them on. I think, if it was just like, oh, you got something there, you need to go to Ochsner, you need to go to Moffitt or somewhere else, I think that they might also get lost in the shuffle and the delay in care. So I think we need to partner with our, like the urologists and the physicians in the community. But it's really the next steps should be done at like a high volume center.
Very well put. I'll move things over. We'll go back to kidney here for a second. Dr. Arcot, thanks to you for bringing us through that variety of biomarkers in RCC. And as a medical oncologist, I've always been very remiss that to date we haven't had anything that has gotten widespread clinical uptake. I think we can all agree on that. Thinking about the different stages that we might find a biomarker to be most effective, the two places that kind of come to my mind would be in adjuvant therapy, and I think we talked about that a little bit, but also potentially the management of small renal masses with a decision between active surveillance and surgery. Where in your, like, how do you work through who you're going to take to surgery for a small renal mass, and where do you think an opportunity is there for one of these biomarkers that you were thinking about?
Yeah, I think a lot of people are working on it. It's a great question. I think there are small renal masses that have high Fermin grades, and we're always surprised when we take them out, and we're like, wow, we thought about putting this person on surveillance, and they could have easily metastasized. I think the radiomics has a certain opportunity there for distinguishing potentially low-grade renal masses from higher-grade renal masses with certain characteristics on grayscales and imaging structure and so on and so forth. I think, again, a lot of the details on how those radiomic profiles are made is not, it's not in the meat of the paper. It's supplementary tables and figures that you have to sift through. So it's hard for me to speak ad nauseum or in depth on that. But I think radiomics is probably a good place to start. I think protein biomarkers are going to be another good place. I think girentuximab is going to be a big player in this. I mean, identifying benign from malignant small renal masses. I think it's going to be hard ultimately, though, because the two most important factors that we know for prognostication are probably size and grade. And so how are we going to determine grade, I think, is going to be a difficult scenario, but maybe radiomics will answer that.
I'll keep picking on this subject a little bit. How about in the setting of something like a cytoreductive nephrectomy? Because I know you would love to probably talk about some thoughts on cytoreductive nephrectomy and who you want to take there.
Yeah. So I think I alluded to it a little bit. I mean, I think that the problem that we face at present is that not all metastases are made the same, and there's a certain amount of heterogeneity in the metastases that are present in patients. So we know that lung metastases respond better than liver metastases when bathed in immunotherapy, quite frankly. But I think that ctDNA has, in certain small series, shown some promise in identifying those patients who would benefit from de-escalation of therapy after cytoreductive nephrectomy. I think what we really need is a biomarker that's got strong negative predictive value, and ctDNA probably falls just slightly short in that realm, but using it longitudinally could be helpful. KIM1 has been shown to have some benefit, but again, we're talking about something that hasn't been, there's no threshold marker yet, and there hasn't been any prospective validation studies, and there's only been some retrospective data present. But I think ctDNA has good promise there. I think the radioligand market could help us identify certain patients who are really cleared of their disease. I mean, if we have a clear cell carcinoma patient with positive CA9 in multiple sites, we've given them immunotherapy, we've given them radioligand therapy, and now we can't find any disease, I think that those are good candidates for a cytoreductive nephrectomy. So I think integrating the biomarkers is probably where we seek to gain the most next.
Excellent. I think across many different spaces in geo-oncology, how we can utilize these ways to de-escalate therapy. Like you're saying, for our patients with renal cell carcinoma that have had, very good longer-term responses. Prostate cancer, I think, is also probably another obvious target where we could start to think about how we can safely start to de-escalate therapy. I look forward to some of that coming later. Dr. Zemp, I'm going to go back to you for a second. Again, thinking about kind of rare cancers, we notoriously have very low, high grade, level 3, phase 3 evidence for a lot of these cancers. But that doesn't really help the patient that's sitting in front of you. When you say, hey, this is, only 4 men in Louisiana got diagnosed with this year, the guy sitting in front of you doesn't care about that, right? So how is it that you evaluate these kind of smaller series, and what is it that you're looking for in these lower level, bits of data that you can then pick and choose as you formulate your own your own practice for something that doesn't have clear guidelines? Like what is it that you're looking for in some of these trials to differentiate the good from the bad?
Yeah, I mean it's a challenge to manage some of these patients without this high level data. So, you know, some of the things that I think are important are to not just read the trial. Sometimes you need to actually be at the meeting and hear what some of those thought leaders are saying and why they're saying that. What am I looking for? I'd be looking for multiple studies that have certain patient populations based on their nodal status, their TNM staging, and seeing what kind of therapies they got. And I'd like to see kind of a collection move together or like move in the same direction. Sometimes there's those meta-analysis that we showed to see, if you put a big group of patients together, is that going to help? So sometimes combining those data, and there are people who are much smarter than me who are doing that and looking at that. But some of the things that I've learned the most is just being at meetings like CAGLA here and talking to people who manage them, and or other meetings around, and that's really kind of helped me.
Kind of getting back to that too, as a medical oncologist, I really dislike giving tip. As you alluded to, it is a difficult regimen that oftentimes requires inpatient resources. And oftentimes patients are not, you have to have a relatively fit patient to go through a chemotherapy like that. What's so special about a regimen like TIP other than that's what happened to be in the phase 3 or the phase 2 trial that had 30 patients? And, is there any role, if we could get somebody on a clinical trial, that'd be great. But we don't always have access to those, and we can always try to get patients there. Is there any role for, extrapolating from other, tumor types that are similar? We know how to treat anal squamous cell carcinoma pretty well. We know how to treat, cervical squamous cell carcinoma pretty well. I know what different kinds of chemo regimens might work in those settings. Am I making a mistake if I take my experience in those other similar settings and try to apply them outside of a clinical trial? I don't know if I'll make you answer that. It's something that I wrestle with. Yeah, you can answer it? Okay. Yeah, okay.
So what's so special about TIP? Absolutely nothing, but the stuff before it was garbage. So cisplatin, it had like an objective response rate of 15%, 5FU, and cisplatin like 16%. And so why TIP is because they had that 15% complete or objective response rate. It's not good. We know it's tough. So I think one of the challenges is when we step outside of the guidelines, when we're off clinical trial, that might open physicians up to questions and litigation. And that's, none of us want to be sued for something because ultimately we're actually trying to help these patients. Now there are many clinical trials open, and kind of like reviewing some of these clinical trials prior to talking about it. I didn't go into details, but there are clinical trials open with penile cancer or with HPV associated tumors that are not specific to penile cancer, but penile cancer would be included with them, including like engineered T cells and additional therapies. So I think that when we step outside the guidelines, we open ourselves up to questions, and that's a little bit scary. Ultimately, we're trying to help patients, but sometimes we don't know if we're going to harm patients and what that's going to lead to.
I appreciate that reality check. I need it sometimes. I'll go back to Kyle for a second. Kyle, you alluded to microRNA biomarkers in seminoma and germ cell tumor more largely. How close are we to doing this? And if you were to take a patient to RPL&D tomorrow for a stage 2A or 2B seminoma, would you send a microRNA assay if you had access to it?
That's a great question, Brian. I think that you could ask the same question for bladder and renal cell for ctDNA, right? the data there is very promising. We don't yet have prospective studies to say the benefit or the selection of different therapies, right? MicroRNA, like RCC and ctDNA and bladder cancer, the strongest data there is in the more advanced tumors, right? So selecting a patient for surgery, kind of like your question for Ro about the small kidney mass, that's a low tumor burden, and the likelihood of fidelity in that test is slightly lower. How far are we from microRNA? I'm guessing, and I'm going to ask Dr. Zemp too, I'd say probably the next 1 to 2 years. There's 3 current prospective studies ongoing with this. The rest were prospective studies that are retrospectively analyzing that data, which, as you know, is a caveat, and it's by definition not a prospective study, right? If you're retrospectively asking a question. It's not commercially available yet, but I think if you counsel the patients right in the way of the strength behind the data, I think you're well within your rights to order it, much like a ctDNA, right? We have to counsel the patients on what this data does and doesn't mean, acknowledge that it doesn't necessarily guide therapy, but it may be prognostic, at least in the initial years.
I haven't been looking up. I'm not sure if anybody has any questions out there. Could be about anything. All right, I'll keep going. Why don't you operate on S1 tumors? If it's, let's say their beta HCG is a little high, but they've got a 2 centimeter retroperitoneal node, it's not surprising that that's making HCG, right?
Thanks. I'm going to answer in front of my mentor. It's a no. You get your hand slapped for doing that in the OR. So with someone who is S positive, and I would actually back up what I said earlier. I think for the purposes of my talk, we do not operate on S positive patients. There are salvage RPLNDs in which a patient is post chemotherapy, post bone marrow transplant, persistently marker positive with minimal sites of tumor that we can then surgically explore and remove. Those are very few and far between. I've seen one. The other thing to consider is that it's not necessarily marker positive. If you look in the AUA, in the NCCN guidelines, it's an AFP less than 20. They say we don't choose a treatment based on an AFP less than 20, right? That might be elevated AFP, but that's not technically S1 if you're considering different treatment options. LDH is not used by most of the major centers that do test this cancer. It's just excluded. It's not a tumor marker because it's not unique to that type of tumor, right? It can be increased in several different states. The question about beta HCG, I think that the likelihood of a recurrence and cure for the patients is lower in tumor marker positive patients. That's sort of the dogmatic approach, is that somebody who's truly S positive, the likelihood of you curing them with surgery alone is low. And so we give them upfront chemotherapy. I will defer to my colleagues though.
I mean, Dr. Rose is hilarious when he says I'm his mentor because like 3 years ahead of him or 2. But the guy who is both of our mentor, Dr. Sexton, he had the saying, and he stole it from somebody at MD Anderson, is people with marker positive, you bathe them in chemotherapy because you're not going to cure them by surgery. And so why do a big operation on somebody and put them at risk if it's not going to help them? And that's the way I kind of think about it.
Yeah, I think it comes down to something that we alluded to a little bit, maybe, or maybe I didn't in my biomarker talk, but we're looking to cure people in testis cancer with like a minimum, amount of disease, a residual amount of disease that's very small. And when we take people to RPLND, it's not that we're going there to always find viable germ cell tumor. In fact, a lot of times we're hoping to find teratoma that doesn't have a marker, a serum tumor marker present, but something that may have malignant transformation later on down the road. Quite frankly, when we do find viable germ cell tumor within the nodes, we worry about having to give more chemotherapy on the back end. So I think what we're trying to do with surgery is just clean up what little disease is left. to avoid further therapy moving forward. And so I think if you think about it that way, I think it makes sense that we don't operate on S-positive disease.
And I appreciate that, because as a medical oncologist, it really is my one chance to shine, where I can actually cure a person with what I do. And so I'm not sure how I feel about you guys coming in and trying to steal my glory there. Oh yeah, we got a question in the back.
I just want to make a comment. Say thank you. I was diagnosed with testicular cancer when I was 20 years old. HCG 156,000. Metastasize my lungs. Taking apples, false curtain RP on D. After 4 rounds of BEP, I did RP on D, and that was 26 years ago. And cured. Nerve sparing. I have 3 small boys. And all natural. So, that's awesome. The thing about RP on D. What I do it here, because I was in Indianapolis, and that was tough getting back to Mississippi after that long surgery. So, being able to do it locally, a lot easier on me as well. So that was 26 years ago. So, I mean, great things. But it sounds like, I did 4 rounds of BEP before the surgery. I think that's changed a lot probably. Would you, like 3 rounds typically, or less chemo, and then do RP on D? Or I guess all the things, mine was non-seminoma, so a little more aggressive. So
Yeah, I mean, we're interested in, that's what an amazing story. And that is just a testament to, where we are with testicular cancer, because we are so fortunate that it's something that we can get these sorts of good outcomes for. And so, I very much, thank you for sharing your story for that. It makes us always feel good. And it's so nice that we can be in a position where a lot of times what we're thinking about with how do we manage testicular cancer, because we can oftentimes get such a good cure rate from it, is how can we de-escalate therapy without sacrificing oncologic outcome but maximizing long-term safety and toxicity, exactly what Dr. Rose here was talking about. If we can spare some people the toxicity of cisplatin, then maybe we should be doing that. Kind of speaking to where we are at that, if we're treating, we haven't come a long ways in where we are with chemo for that, to be honest. If we're treating, low risk disease, then yes, we can come down to 3 cycles of BEP, or we can, omit the bleomycin and do 4 cycles of EP. But that hasn't really changed very much recently. And for high risk disease, we're still looking at 4 cycles. Yeah.
I'm just going to add a comment. Thank you for sharing your story. I was thinking about this earlier. We're talking about penile cancer, kidney cancer, and bladder always comes up too, where we're arguing about how can we help patients improve their survival, right? How do we save patients, or at least grant them longer life? And I think it's really cool that in testis cancer, we're sitting up here arguing. I mean, my actual talk is arguing how we minimize treatment that we know works really well, right? I mean, the survival is so good. It's phenomenal. And it's so nice to be able to tell patients that right off the bat, that, yeah, you have choices, but the outcomes here, we're choosing our poison a bit, and we're in a very separate space for that tumor type compared to others. So.
All right. I think I see Chad lighting up the band maybe for us. So, yeah. If you guys stuck around this long, you get your drink tickets. Thanks for everybody. Yeah. All right, excellent. Thanks, everybody. Enjoy the second line. Wouldn't be CAGLA without it.